Good morning, good afternoon, everyone. Thank you for joining us today. We'll get started here in just a minute. We're just gonna give a couple more seconds for more people to join. Okay, great. Well, thank you everyone for joining us today. My name is 𝗁𝗶𝗺𝗲𝗆 and I'm a nutrition specialist with UNICEF HQ. We're really excited for day 3 of the Simplified Approaches learning event. Today, we're gonna take a deep dive to learn more about community health worker-led treatment. The session will be facilitated by Andrew Beckingham from Save the Children. So Andrew, over to you.
Thanks, Grace. Welcome to everyone who's joining us today. Hopefully everyone is able to hear as well. There is translation available into French and Spanish, so please just click on the interpretation button on Zoom to change language if you need to. There is a chat function if people would like to introduce themselves. If everyone, as we go through the presentations, have any questions, please place those into the question and answer channel. We'll be monitoring that, and we'll be making sure that as many of those questions are put to our speakers and panelists today as possible. So we have a couple of learning objectives for today. So we're going to be looking at hopefully everyone to gain an awareness of the key tools and the use of the simplified approaches for the treatment of wasting through community health workers, looking at some of the key approaches, and also having around the scale up for treatment, and also the key approaches for the monitoring and evaluation of CHW-led treatment. So that is what we're going to be doing today. I'm going to hand over shortly to Emily, who will provide a quick overview of the approach. We've got 3 really exciting country-focused discussions. The first one from Senegal with Dr. Mati from the Ministry of Health and Ali Traore from ACF joining us to talk about monitoring and evaluation within Senegal. We'll be talking to Save the Children, exploring policy and advocacy work around community-led treatment, and then we'll move to a case study for Somalia, led by IMC, presented by Samuel Kopi and Naomi Ndungu. And we'll be finishing up with a panel discussion with everyone available to pose questions to. So let's get into the more interesting bits, and I'll hand over to Emily.
Thanks, Andrew. So as Andrew said, I'm going to just attempt to give a very brief overview of what is community-led treatment and some of the global evidence that's emerging as well. So kind of to start off, what is the aim of community-led treatment, community health worker-led treatment of wasting? It's really a strategy to improve equitable access and coverage of the management of wasting. And it's an approach that's particularly relevant in contexts where treatment and care at the health facility level may be inaccessible for some parts of the population. In terms of the what, it covers both the diagnosis and the management of uncomplicated wasting. And this can vary by context. So in some places, this may cover severe or moderate or wasting. In others, it may cover both conditions. And that treatment is actually delivered by the community health worker themselves. We also commonly see that this is integrated into an existing community health service. So one of the most common platforms that we see it being integrated into is integrated community case management. So kind of management of common childhood illnesses by a community health worker. We also see that it's typically the protocol that the community health worker follows will be implemented with other simplified approaches as well. Next slide, please. So kind of what is the evidence telling us? So there have been a number of really good and useful evidence reviews that have been conducted recently that kind of summarize the experience of practice and evidence on this approach. So what that has told us is that it's one of the most common simplified approaches, and it's also one of the ones that was implemented earliest. We see that typically it's implemented with a NUAC-only protocol. So 60% of places where community health workers treat, they use a NUAC-only protocol. And it's also very often linked with community detection, and particularly the family NUAC approach. The evidence also shows us that it's typically an effective approach in a number of different ways. So we see that community health worker-led treatments can produce very good treatment outcomes. So we see good recovery rates, high recovery rates, and this is often linked to low defaulter rates, which is often because of the kind of decentralization of the services. We also see that community health workers can provide a good quality of care, and that's often linked to a strong supportive supervision structure. There's also evidence to show that the approach can improve coverage. So it really does link back to that objective of improving access and equitable access of care. And while the evidence is relatively limited so far, it hasn't been measured in many places. But in the places where it has been measured, there is some emerging evidence to show that the approach is more cost effective than health facility-based care alone. So as with all simplified approaches, but particularly with community health worker-led treatments, context is really crucial. And there are a number of considerations that need to be taken into account for successful scale-up and sustainability of the approach. So I think it's going to be really interesting hearing from the countries about how some of these issues have been dealt with. But some to highlight, first of all, kind of supply chain. So we all know that kind of supply chain of nutrition products can be challenging, even to the health facility level, but there's a whole new set of issues that come with decentralizing a step further to the community level. Thinking about appropriate tools and guidance for community health workers, particularly when we've got quite different profiles of community health workers. I think one example will be looking specifically at low literacy health workers. I think that would be interesting to hear kind of some of the adaptations that have been made there. Thinking about the community health workforce at large. So kind of what's in place around kind of training, motivation, retention of community health workers. Then more at the kind of macro level, policy and guideline adaptation and adoption. So in many places, it isn't currently part of national guidance that community health workers can treat wasting. So there's a whole process and steps to think about to move along that pathway. And then lastly, but very importantly, the financing of the approach. So kind of where does that fit with broader community health worker financing and issues and challenges that are commonly in place. So I'm going to finish there, but really looking forward to hearing the country case studies.
Cool. Thank you, Emily. Just bear with me whilst I change the presentation over. Okay, there we go. So I'm delighted to introduce Dr. Mati from the Senegal Ministry of Health and Dr. 𝗹𝗶𝗸𝗲𝗆 from the ACF office in Senegal as well. And they will be, I'll let them introduce their session much more accurately than I will be able to. Dr. 𝗹𝗶𝗸𝗲.
Bonjour. Bonjour, merci André pour l'introduction.
Good morning, thank you for the introduction. Dr. 𝗹𝗶𝗸𝗲 has not been able to join us in this call, but maybe he will be here to join us during the questions and answers. I apologize, there's an audio difficulty. Yes, she just joined the call right now.
Oui, voilà, docteur
Allô, je me
Mathieu.
suis connectée.
Yes, I am connected. I am connected. Hi, I'm connected. Yes, thank you.
Bonjour à tout le monde et tous
Good
mes
morning to everyone. I apologize. I had some connection problems. It's a pleasure to be here to participate in this session on decentralization. I apologize, audio difficulties. I cannot hear the speaker. This is the interpreter.
de la malnutrition aiguë. Slide.
Next slide, please. Next slide, please.
S'il vous plaît, diapositive.
Okay, perfect. Learning objectives for the session.
De la session, suivre l'intervention des
This is
agents
for the intervention of the community health workers
au niveau local, mais
at the
également
local level to follow up CHW intervention at a country, regional, and international level. Define a system and to do follow-up intervention at the local, district, region, national, and international level. Next slide, please. Next slide, please.
diapositive.
Next slide, please. Okay. What's the agenda for today? First of all, we will define the tools for collecting information, objectives and indicators, the report system for follow-up, and to define the next steps. Next next slide, please. So for this ICCM approach for the decentralization of the severe malnutrition at the community level in the context of Senegal, we see how the COVID caused some difficulties. So this acute malnutrition has been, we have also the need to encourage to overcome the obstacles, the distance between the community and the place of the services, insecurity and violence. These are some of the challenges, and also we need to help mothers and family who are also at the hospitals. So we need to have a simplified approach for development in terms of humanitarian aspects. Next slide, please. So the results, what are the evidence that we were able to learn about in terms of the ICCM approach? The results in terms of acute malnutrition, we have a lot of reports in terms of the managing the illness and the service. We need to look at the services from the community, the nurses. These were better. We need to see that there are less problems in terms of community services. We need to have more coverage, and in 𝗹𝗶𝗸𝗲 complex, we have the evidence, scientific evidence. The community workers have a potential to improve detection and early detection. We have risks of complication. So at the community level, we do have the detection and also to avoid complications. Yes, I apologize. Can you please talk a little bit slower because we have translators? Okay, I'll go over. We have scientific evidence in terms of the 𝗁𝗍 plus approach. The results in terms of the treatment of severe malnutrition and the indicators, which are the rates of abandonment, the possibility of improvement. We see the results are needed in terms of structures. As I said before, the beneficiaries are close to the structures at a community level, and we will see that the rates of difficulties will decrease. We will improve the coverage of children affected by malnutrition in different contexts. The community health workers, we see that they have the possibility of improving the situations and given the appropriate treatments for children in turn for eliminating the possibility of more complications. The supervision also for this intervention, these community workers have had good results in terms of the children that are not supervised. We need to have more supervision by the community health workers or in the community. They can work in the context of development, help also in a humanitarian context. These community health workers are in the middle of the communities. Next slide, please. Thank you, Doctor. I will also continue. I will go quickly because we don't have a lot of time. The tools that we have developed, the first tool in terms of collected information on practices to also look at the aspects of severe malnutrition. We have information also on monthly management of the severe malnutrition. Another tool is to also look at the evolution of each child. Also, we have information, we collect information on demographic aspects. Next slide, please. Next slide, please. This tool has
Vous êtes en mute.
Sorry.
You're on mute. Yes, this tool is for the monthly follow-up of the 𝗁𝗍, and it has general information on the 𝗁𝗍, questions about or topics on the activities, the country coordination. We also have information on the chain of provisions, morbidity, and also to information and malnutrition. All of these information are also connected in terms of the malnutrition, acute, severe, and moderate. All of this information is has been collected. Next slide, please. In terms of supervision, the information comes from the context of the 𝗁𝗍. We have to see the state of the equipment, the registration, the equipment. Also, we have direct observation, that we see the signs of danger, the physical aspects of the children, the identification of each case is good to give advice to the mothers. And now, next slide, please. This is also a tool that gives information by sex, the country, the village, etc. We have a type of admission, type of examination conducted. We have information also about the warehouses, signs of danger, also the condition of the health condition. Next slide, please. Objectives and indicators. It's important to mention that we have to identify all of these objectives, and in general, the treatment of the malnutrition has increased, as Dr. Mathieu has mentioned. We have main objectives to identify the situation, control the situation of the health workers, analyze the quality of the services, those who are affected, and we also look at the medications necessary. We need to analyze the integration of the moderate or acute illness and look at the coverage, looking at the cost effectiveness. Next slide, please. The indicators, we have the indicators at the level, health level. We need to look at decentralization. We look at the percentage of those who have recovered, percentage of those who have been affected. Next slide, please. The indicators, in terms of the conditions, we have the percentage of people who have drinking water. We have the percentage of those who have had the tests and diagnostic. We see the conditions of storage of medications. We have the percentage of all of these indicators. Next slide, please. We have indicators that analyze the quality of the management of, and we have a lot of indicators in terms of health, to identify all of the signs of dangers, percentage to see whether the MOAC has been used appropriately. And also we have, we look at admission and the amount of children that have been able to be successful. Next slide, please. These indicators also measure the follow-up of the stock. As I mentioned, we will see the percentage of stock for nutritional uses. We look at the stock of medications as well, the percentage of medications, and also stock of vitamin A. Next slide, please.
Thank you, Dr. Ali. You've got 1 minute left, I'm afraid.
Next slide, please. We have also indicators in terms of the work at the community level. We have acute, severe, and moderate cases, diarrhea, respiratory problems as well. Next slide, please. Malaria. So this also shows us the system of follow-up and evaluation and the different levels, community levels, at the national level and regional and international regional. Next slide, please.
Dr. We just need to finish up now. So if this can be your last slide, please.
We have here an example of analysis from 𝗁𝗶𝗺𝗲𝗀. This is a systematic analysis. You see here the motivation, financial motivation, yes or no. They will indicate here whether they have been motivated and also if they had participated at the community level, yes or no. So this is the use of a 𝗁𝗶𝗺𝗀 to give you a visual idea of the coordination. This will help you guide the supervision in order to take decisions. Next slide, please.
So Dr. Alu, Dr. Matthew, I'm afraid
Dr.
we're running out of time now.
Dr. Matthew.
So thank you very much for your presentation. But are there any questions, Sophie, for Dr. Matthew or Dr. Alu?
Would you please allow me to do the last slide?
Of course.
Okay. Merci beaucoup.
Thank you very much. For the next steps, we will need to have a joint supervision for the decentralization in order to improve the acute and moderate malnutrition. And we need to work together with UNICEF, 𝗁𝗶𝗿𝗄, and other colleagues in order to supervise at the health level. Then we will evaluate the information, integrate also the information at the community level in terms of the moderate and acute malnutrition. And we have also a program developed by the Ministry of Health. Thank you very much.
Dr. Matthew, Dr. Alu, thank you very much. Sophie, are there any immediate questions on that presentation? If not, we can move on and save them for the panel discussion at the end.
Thanks, Andrew. There was one specific, there are a few specific questions. Let me just take one in the interest of time, from our colleague, 𝗁𝗶𝗺𝗲𝗃, who asks that there are several indicators at community level, knowing that the community health workers are often have a limited amount of training. Who's responsible for all of the different registers and tools at community level? Donc pour Dr. Mathieu et Dr. Alu, la question c'était qui était responsable des différents registres et outils au niveau communautaire?
Who is responsible for the different registration tools at the community level?
Oui, allez-y.
Oui, en fait, c'est
yes. The first level supervises the community workers. They have the management, they have the registrations, and when we have when we're supervising, we look at these tools that I just mentioned. So we have the main nurse who is responsible for administration of these tools. Here at Senegal, we have the ASF team, which is strongly involved also to supervise at the spots. The administration of these tools is done also with other collaborators.
Back to you, Andrew.
Dr. Mati, Dr. Ali, thank you very much for those really fascinating insights, and look forward to discussing further with you during the panel discussion at the end. So now we'll move on to looking at the integrated treatment of uncomplicated and severe moderate acute malnutrition into ICCM with a case study from Kenya. So I will hand over very quickly to Linda and James, who are child technical advisors and nutrition technical specialists for the Kenya office at Save the Children.
Yeah, thank you, Andrew. Confirm you can hear me.
I can hear you well.
Yeah, thank you. Yes, this piece of work was conducted in Kenya, and what we intend to discuss with you today is how we did the advocacy for this work, and what our experiences are, and probably what recommendations or learnings we can share from this piece of work. To start us off, Kenya launched the ICCM framework and action plan in 2013. And during that launch and ICCM scope did not include treatment of acute malnutrition by community health volunteers, simply because the policy does not allow them to do that. So what happened is that the CHWs were mentioned in that implementation framework, but there was no detail on how that could be advanced. So the advocacy for treatment of acute malnutrition by CHWs in Kenya started quite a long time, and it took us quite several years before we could have a breakthrough to implement this study. So we did it with the other stakeholders that I'm going to share slightly later. Maybe you could take me to the next slide. Yeah, so treatment of wasting was in Kenya is largely restricted to the health facilities, while CHVs are allowed to treat malaria, diarrhea, and of course now pneumonia. And from what you are seeing below there, Kenya then around 2014 was categorized to be somewhere around typology 3, where CHVs were only screening and referring the CHVs. And there was a desire to take Kenya to typology 4, where CHVs could be allowed to treat acute malnutrition. So this study was around two things: to provide local evidence that CHVs can treat acute malnutrition in Kenya, and then two, what does it take to have this treatment at community level in terms of a supply chain, and what would be the risks around allowing CHVs to handle RUTF. We are coming from a situation where the government had been put to task to account for lost RUTF, and therefore there were very high sensitivity around allowing CHVs to treat. So we had huge task to convince stakeholders and government that this piece of work could continue. Next slide. So how did we go about it? Around 2016, Save the Children and ACF came together and made a case. And then they moved out to respective technical working groups to try and convince them that we have an opportunity to provide local evidence that this could work. So one thing that happened is that we identified the stakeholders who are key in Kenya to influence policy, and therefore we made sure that we have them on board. These included UNICEF, WHO, and WFP as well, and then other strong nutrition partners. So the resistance were coming from 3 different sources. The first one was internal, like our nutrition colleagues were not really willing to allow CHVs to handle commodities because they felt that if commodities were getting lost at the health facility, what does it mean to take them lower to the community where CHVs are not really, there is no mechanism for accountability for CHVs then. So that was the first barrier. But at least we managed to convince our nutrition colleagues through presenting global evidence. And I remember we even invited IRC to present some work they did in South Sudan to tell them, yes, this is possible, and we could be having an opportunity to test it in Kenya. Then after that, we made some breakthrough, and it was agreed that we needed a task force to work through with ACF and Save the Children to be able to think through how that will be done. And through that task force, then we made several presentations and inroads to other colleagues in child health and also community health department. And there was largely now a consensus. That process took us close to 2 years, but then finally we were able now to convene a stakeholder workshop where we brought now all the different constituencies together and agreed that we will conduct this study. And it is out of that it was recommended that we establish a technical advisory group that is led by government, and then the implementing partners were part of it. And government here included the 3 divisions or department, that's child health, nutrition, and community health strategy. So it is out of this now that we were able to also go to the county level and did the same advocacy now with the leadership of the national government. And therefore we were able to establish now implementation structures. And in those structures, we made sure that the government is in the lead, providing leadership and convening meetings. And therefore, our role was largely to facilitate for government to provide that leadership. And that way, we were able to have approvals and even at county level to be able to implement. Next slide. So this slide shows what we went through in terms of developing terms of reference for different implementation structures and positioning government to be able to provide leadership, for largely also ownership on key steps. For example, approval of protocol before even we applied for ethical clearance. We had several conversations and the government put input and agreed that this is how they want it to be done. I must say that they were very cautious to allow CHVs to treat severe acute malnutrition. They were saying this is a very delicate case, and they don't believe it will be feasible to allow CHVs to handle severe acute malnutrition. So this took a lot of consensus building. So at county level, we made sure there was a committee that was looking at the bottlenecks for implementation, and therefore the national level government felt that at lower levels, the government was still in control. So these structures helped us to implement and address bottlenecks as we moved on. on rolling basis. And for example, challenges with the commodity supply and the pipeline breaks were largely addressed first at the lower levels, at the facility level and then county level, before the national level could come in to address the problems. We, however, had to procure some buffer stocks for commodities when the supply chain were a bit of a challenge. Next slide, please. So when we were ready to implement now the study, this slide shows the design of the study. We had we started this work in 2018, where we had the pre-randomized control trial phase, where we enrolled a cohort and followed them all the way to discharge, and we documented the outcome of that treatment, where CHVs just screened and referred to the health facility. That is what they would call the standard care. And then during now the intervention phase, the RCT phase, the CHVs started to treat acute malnutrition at home. And then we followed a cohort all the way to discharge and then documented the treatment outcomes. Next slide. So this slide shows the treatment outcomes, and largely on cure rate, default rate. And what we wanted just to demonstrate here in summary is that the intervention had improved cure rate compared to the control. And also we had reduced default rate in the intervention sites compared to the control. But we had, although we had observed improvement on non-response rates, that was not statistically significant. Next slide. So this slide again is just wanted to demonstrate that the treatment outcomes by community health volunteers was non-inferior to the standard care. And this is evident in the fact that you can see the point prevalence for cure rate, for example, is on the positive side and did not cross the 0 line, neither did it cross the non-inferiority line. So this demonstrates that the treatment by CHVs was non-inferior to the standard care, and you could even say it had better outcomes compared to the standard care. Again, it was observed in both sites, and therefore we were able now to provide that evidence that CHVs can, one, treat, and the treatment outcomes are non-inferior to the standard care. Yeah, next slide. So what practical implications we learned from this work that is important for any for example, country willing to carry on or scale up this. One, we noted that before you initiate CHVs to start treating, is important to even do geographical mapping, because those CHVs that are near the health facility, probably if they are also treating, then you may not have any impact on coverage. And for us now, the emphasis is now to ensure that the CHVs who are far away from the health facility are the ones that actually prioritize to treat acute malnutrition. Then two, it is important to also bring into context different situations within the country. For example, in Kenya, we have different settings, and the cost to undertake this intervention will vary from one setting to another. I will be sharing our next steps on how we want also to increase evidence on the costing of scale up of this intervention. And also more importantly, we also learned that the supply chain should largely be mainstreamed within the government system. And however, there need to be plan B for instances where there is a pipeline break, because for us, what we noted that when we, despite having put all the measures around ring fencing the commodities for these intervention sites, or the study areas, we still encountered some breakdown of supply chain. So it is important to have that well planned, and probably some plan B measures. Number two, it's also important that the criteria for referral need to be relooked, because in our study we also noted that we had quite a significant number of referrals, not because the CHVs could not treat, but it's because of the how we had set our protocol. And therefore, as we move on to scaling up this intervention, we will be able to relax the referral criteria so that majority of those children who are referred do not necessarily get referred because of the protocol restrictions. And so then the CHV expanded role need to be discussed with the community leaders, because at some point we noted that they are able to oversight the CHVs at community level, and therefore the community need to be sensitized upfront on the added role for CHVs, especially when you are adding on treatment of acute malnutrition onto what they have been doing as ICCM treatment of childhood conditions. And then, for example, if you train the CHVs, it is important that you deploy them as soon as possible. And we found that in areas where this happened, they had high retention of knowledge and skills, and their performance was better. And so it is important to make sure that between training and the time they start actual treatment, it should be minimized as much as possible. Then in one of the sites, we were providing some incentives for CHVs, for example, facilitating their transport and facilitating meetings, while in another site, there was no provision of that from the implementing partner. So what we learned is that where there is some incentive for CHVs, it is important to motivate their output. However, they are equally motivated by the fact that they are able to provide solutions to their community members, even when there is no monetary incentive. Yeah, next slide.
So James, we just need to make this your last slide, please.
Yes, this is my last slide. So what we noted is that the counties were able to request for national government to give them a waiver, a policy waiver, because they were able to attribute this intervention with good outcomes, and they were able to see that this intervention were implemented is able to save lives. And therefore, even as we continue with the policy discussions to change the guidelines to allow CHVs to treat, we have seen this request coming from the county governments. We are also doing a wider dissemination on the on these studies in areas that we haven't maximized. And more importantly, we still have some professional bodies that we want to engage as we continue to disseminate globally. We want also to build on the momentum on pneumonia change of guideline where recently we have managed to have CHVs be allowed to use antibiotics at community level. And that momentum is what we will be utilizing to fast track policy change for treatment of acute malnutrition. And finally, we are at advanced stage now with the manuscript, and we hope to publish and influence the ongoing review or revision of the formative guidance by WHO on management of acute malnutrition. So we have planned a larger scale pilot in what we are calling phased scale up. And in this study, we intend to investigate further the areas that we did not exhaustively investigate in the RCT. And we are hoping to also integrate some of the new evidence that is coming along as we scale up treatment of acute malnutrition. So the last slide is about the stakeholders that we implemented with. Please show the last slide. Yeah, those are the key partners that worked on. But over time, we have been able to manage to pull along many more partners who are willing to implement this intervention in their areas of operation. Thank you. Back to you, Andrew.
Thank you very much, James. Super interesting presentation on your experiences around policy and advocacy for Kenya. We're just running slightly behind. So James, I think we'll save the questions for the panel discussion, if that's okay. And we'll move over to the International Medical Corps presenting on Somalia. So over to, I don't think we've got Naomi on the call, do we? So, sorry, I think we're handing over to Samuel at this point.
Yeah, good morning, good afternoon, good evening, depending on the place. This is Samuel Kopi from International Medical Corps. Just confirm that you are hearing me.
I can hear you well. Thank you, Samuel.
Okay, thank you. I'm still waiting for the slides.
Can you not see this?
I can't see this.
Sophie, can you see the slides?
Yes, I can.
Okay, I'm going to stop sharing and I'll reshare them.
No?
Okay, Samuel, can you see the slides now?
Yes, I can now see the slides. Yeah, we are just looking at IMC for Somali and South Sudan. So currently, in Sudan, currently I'm in Sudan, in Khartoum, that we are looking at these ICCF plus. So just a definition of community-led treatment. We are looking at the approach where we have diagnosis of and treatment. Diagnosis management of uncomplicated cases of acute malnutrition, pneumonia, malaria, and diarrhea among children who are of age 2 to 59 months. This management is done at community level, which is contrary to what we've been doing at the facility level. So these are the cases that are being managed at the community level with the CHW or CNVs using a simplified approach where complicated cases are referred to the facility. The main objective of this approach is to improve the coverage and also treatment of acute malnutrition among these children. Thank you. Next slide. Yeah, we are just looking at the state evidence that has been shown is that there is a close linkage between these ICCM and nutrition services that is for management of acute malnutrition without complication, because we find that a child who is malnourished, most of the conditions that they come with at the facility that they present themselves with are diarrhea, malaria, and pneumonia. So if these children are addressed, these issues are addressed at an early stage, where the malaria, the pneumonia, and diarrhea are addressed at the earliest stage for these children who are malnourished, it ensures that the treatment is done quickly and the coverage rate, children will get cured quickly, and the coverage rate of the costs that are involved into treatment will be low, and also will increase the coverage in terms of how many children that we reach, because most of these areas that we are targeting for this are areas hard to reach. They are the areas which are far from the facility. And this platform provides a very good engagement for the poor and people who are hard to reach. And this population which are hard to reach, thus reducing a long term in terms of ineffectiveness and saving the delivery for the child. Next slide, please. Yeah, we just look at the two countries that we are implementing this project. It is in Somalia and Sudan. So this is a pilot project that was intended to start in July, but it delayed. In Somalia, it was intended to start in July, but it delayed a little bit to December. And in Sudan, it was supposed to start in August. It is just starting middle of December. So these are the projects that are funded by UNICEF. And in Sudan, it's a 12-month, while in Somalia, it's a 9-month project. With CHWs in Sudan 20 and 15 CHWs in Somalia. A total budget of $30,000 for Somali and $26,500 for Sudan. Next. Yeah, what are the objectives of this pilot study that we are having? Just to examine the feasibility and effectiveness of integrating acute malnutrition as part of ICCM package. We want to look at how effective this ICCM and acute malnutrition is going to be effective, and how best we are going to ensure that we reach our objectives. Then to determine the factors and the bottleneck for effective integration of management of uncomplicated SAM and ICCM. So we are just looking at how best we can have the bottleneck and also identify the challenges, constraints, and potential risks. We also want to look at the lessons learned and good practices for integrating these ICCM to SAM management. Then we want to look at to provide policy and program recommendations based on whatever will be achieved at the end of it. Then we can effort to advocate for some policies and also recommend to the program on how best we can do our interventions. Yeah, some of the daily activities that the CHWs or CNBs will be carrying out, or they are carrying out, is management of diarrhea, that is with ORS and the zinc. Diagnosis of malaria using the RTs, and the provision of the treatment with SCT, identification and treatment of suspected pneumonia, screening of acute malnutrition, treatment of uncomplicated case, and the referral of complicated cases. We have also conducting home visit and identification of danger signs in newborn and pregnant. Then they refer those ones. Then promoting positive health behavior and practice through social mobilization, community dialogue, and interpersonal communication. Then filling the forms on a daily follow-up sheets that we will be sharing into the other slides, just to document whatever they have done for the day. Let's move to the next. Yeah, basically the training approach is we have the modules that have been extracted from ICCM Somali, because in Sudan, the ICCM is not really a national kind of approach that we are using. So we had to borrow a little bit of ICCM guidelines from Somali that have been combined with IMAM or CIMAM guidelines to ensure that both ICCM and CIMAM is well covered. Then we target these, the main target was the community strategy, where we are employing or we are using community health workers or community volunteers. Then we have community health workers or community volunteer supervisors, then the health and nutrition officers, then their supervisors, based on the community strategy of different countries of Somalia and Sudan. The training methodologies that we use are buzzing, brainstorming, discussion, and demonstration on how to carry out effectively these interventions. Then the training tools, just the chalkboard, the pictures, the reporting samples, the markers, and how long the training is 5 days, and 2 months refresher training, just to ensure that being a new thing that is being introduced, we needed to follow up after 2 months, which is in the pipeline. Next.
We've got about 2 minutes left.
Monitoring, just to analyze the effectiveness and the impact of ICCM will be done. And how monitoring will be done is IMC routine health information system. The tools that will be used, the baseline, endline survey, the tally sheet, the registers. The data will be collected by CHWs and the CHW supervisor, and how the monitoring of the data to improve the project implementation and programming. Let's go to the next slide, please. So these are the indicators that are that are very essential into our program. We are looking at the coverage, where we shall use the SLAC just to find out the baseline and the endline to see how best we are doing the implementation. Then the human resource workload, we shall be looking at how the CNBs, how many hours per client, how many hours per work per day, and also the literacy levels. The commodities, we shall be looking at the stock out and the correctly accounted for all the supplies given. ICCM service delivery is ICCM condition managed by CHW. We shall be using the registers. On the quality care, we shall be using the program performance indicators to determine how best we are doing. And also CHW will receive at least one visit and the CHW who can correctly classify some in the presence of the supervisors, the proportion of the CHW whose registers are accurate. So these are things that we shall be using as indicators. Maybe the next slide, please. Yeah, this is the register that we developed. These are just the tools that we developed to ensure that all data is collected as a requirement. We have these identifiers, the mission, the pulse, and the ICCM information that is required, plus also the nutrition information. So very important is that these registers will be like they are in local language, and these tools are being done for in local language where the CHW can understand well. So the registers is just a continuation on the nutrition part. Move to the next. Some of the lessons learned from this experience, just that we are in the important to work closely with the health team to ensure that full integration of the training tools, the training, the tools, and implementation, because we are just at the starting phase. So this close working with the health team is very important. The importance to work closely with MOH required approval and endorsement. For them to honor it, it's very important to get the approval and the endorsement. And also inception of pilot requires a lot of time and designing. It has taken us quite some long time to ensure that this has been done, but we are there at long last. So these are just things that we look at. So next. It's my last slide.
Cool. Sorry, there we go. Thank you very much, Samuel. That was super interesting. They're a great example of what's been happening in Somalia and Sudan. Yeah. So we're just going to move on now to our panel discussion. Thank you to those who have been putting questions in the Q&A box. Feel free to carry on asking your questions. They can relate directly to any of the three brilliant presentations we've just heard, or they can be a more general question around the CHW-led treatment of wasting. So I'm going to ask Sophie if she's got some questions.
Great, thank you very much, Andrew. That's fantastic. So there's a specific question from for the Kenya team, for James, around whether the RCT looked at other outcomes in addition to cure rates. For example, length of stay, weight gain, relapse, readmissions. That one's for you, James.
Thank you for that question. Yes, we looked at other treatment outcomes, and it was very encouraging. For example, we saw a significant reduction in average length of stay for the intervention compared to the control. And then we also noted that the weight gain was slightly higher in the intervention as compared to the control, even though in one of the sites it was not statistically significant, but there was observed improvement in terms of weight gain. And we also conducted the quality of care performance of the CHVs, and we also assessed them whether introduction of treatment of SAM and MAM onto ICCM affected the quality of care they were providing for ICCM childhood illnesses. And the outcome was that did not impact on the quality of care for ICCM. And the CHVs were able to perform over 80%, 70 to 80% of the tasks they were expected to perform. So yes, we did several other analyses on other secondary outcomes.
Excellent. Thank you so much for that very comprehensive response, James. We have another question that is perhaps for any of the three country examples, a question around the IETF supply chain. If we could hear a little more about how the supply chain for IETF worked between the health facility and the community health workers, especially given that stock can become heavy depending on the number of beneficiaries or the number of children needing therapeutic support. So if I could ask any of the three panelists to jump in and give a little bit more information on how the supply was managed with the CHWs.
Okay, Sophie, let me share Kenyan experience because this was a bit quite sensitive in Kenyan context. We initially experienced some reluctance of the facilities to release the commodities to CHVs. In Kenyan context, the CHVs replenish their stocks from the health facility. And at the start, facilities were feeling like they will give the commodity to CHVs, and then the facilities will not have enough to manage their caseload. We also saw some delayed initiation of treatment because of that. We had to do some frequent conversation with the facilities and the procurement system to be able to factor in consumption for the two levels. And that way we managed to have a breakthrough. And then we had two different lists at community level for CHVs who are supervised by community health assistants or community health extension workers. They kept a list on commodity flow, and there was a similar list at the health facility. This is because the facilities could only release commodities if the CHVs presented the number of children they have identified that they are treating. So those are areas that need to be discussed upfront before you initiate treatment, because it's bound to delay initiation of treatment. And then largely, we had to work with the national government colleagues who are managing the supply chain, including huge support from UNICEF and WFP, to be able to slightly provide and do ring fencing for those areas so that you are not caught up with the supply chain breaks. So yeah, that's the Kenyan one. Back to you, Sophie.
Ok. Je peux parler rapidement aussi sur l'expérience du Sénégal par rapport aux chaînes d'approvisionnement des enfants.
Also, I will talk quickly about Senegal's experience in terms of the furnishing of stock. We had the community health workers and the nurses needed to integrate, talk about the access and the focus of the supervision for the community health workers. They had to talk about this situation, and there was some, in order to reach an agreement. We did not have a facility to stock all of the materials, so we had a mobilization, and we had to work with the head of the community to also stock this material or these commodities. Though at the community level, we didn't have the same conditions for medications. We were not able to mobilize these medications appropriately, so we needed to work with the community. And I remember the example of Senegal is recent. We had also to take into account other examples of other countries to help with our experience.
Definitely that the supply chain is really a very important consideration in the decentralized model. I have a question now that I would like to ask perhaps to you, Emily, around, we have a question around the ideal kind of caseload for a community health worker. So in the experiences from Save the Children, how did you go about calculating that workload for the community health workers?
Yeah, it's a really good question. I spotted it, and I'm not sure that I've got like an optimal, like evidence-based answer. I think there are probably a number of considerations when thinking about kind of feasible caseloads for the community health worker to manage. So some of that might relate to kind of what else the community health worker is doing. Are they doing a number of other services, or is kind of wasting management kind of one of the only ones that they're going to be doing? So kind of what's their overall kind of availability? Also some other kind of issues related to, are they paid? Are they salaried staff, or are they a volunteer? Again, that kind of can be quite key in terms of the amount of time that people can kind of give to providing services. I think we haven't quite cracked, is there an optimal number? I think we know there's probably an ideal range. We don't want to have so few children under treatment that the community health workers lose the skill. So we did have a number of cases where maybe a community health worker didn't treat any children at all. So we can't really expect them to be refreshed on those skills if they're not getting the kind of practical exposure. But there's also equally probably like an upper limit as well. So I think, yeah, there's quite a lot to take into account in terms of seasonality, kind of, health worker capacity, motivation, retention, and incentives. So yeah, I don't think we've got, I'd be really interested to know if anybody else from other experience has got any kind of suggestions or insights into that.
Thanks, Emily. Samuel, would you like to come in here to discuss the workload of community health workers?
Yeah, we've tried to employ this community strategy by the government, where we have 200 households per each community health worker. And so looking at these are, we go into the area and which are far from the health facility, just to avoid the duplication, and also to ensure that the objective is well reached on increasing our coverage. Then we determine, there is already determined the data on population catchment. So from it, we get how many CNVs are required based on the population catchment, the households around. So we are basically working with 200 households by each community health worker or community nutrition volunteer. So this is something that has worked very well with the countries that we are implementing.
Thanks so much for that, Samuel. And I know that we have a lot of really interesting questions in the Q&A. We won't be able to get to all of them as we're just coming up until to time. But before we close on this panel, Samuel, James, and Alu, we have lots of participants on the line, and they're all implementers who are keen who either have experience already in implementing this approach or are interested potentially to implement it. If you could give a piece of advice to the audience on setting up and putting into practice the CHW program. I know you've discussed broadly on and given us so much of your experience, but if you could just propose one piece of advice to all of the participants here when setting up and implementing this kind of project, what would that be? Samuel, perhaps over to you first, as you still have the microphone.
All these important things that we've been talking, we cannot overlook them because they're very critical in determining. But the most critical issue is to ensure that the community has, confidence with whatever things that you are doing, the work, the implementation that you're doing. So once the community has the confidence, the community that they are very sure about the implementation that you are doing, about the quality of work that you do. So at the end of it, the acceptance of whatever you are introducing, it becomes very, very easy. But if they don't have confidence in whatever you are doing, if you don't have a good relationship as an organization with the community, that one really brings it down. So we have really taken a comparative advantage of the work that we do and the confidence that the community has, and also the ministry and other stakeholders into our work.
Thank you for that, Samuel. That's a great point. James.
Yeah, my piece of advice for those who are considering to implement this intervention is to, first of all, understand what the objective is. If you ever wish to influence policy and probably in future see scale up of this intervention, for me, the biggest area that need to invest time on is to ensure that government is in the leadership, and there is buy-in on what you are doing. Because for Kenya, we have seen several studies, and they just remain as findings. But I think most importantly, if you ever want to influence policy, make sure that government is in the lead and it is in support of what you are doing. So it may take time, but it is worthy investing in. Yeah.
Thank you, James. And I know we're really running out of time completely here, but just wanted to give, Dr. Adu.
Mon côté aussi, un conseil rapide, en plus de
Quickly also, we also need to look at the local condition. In Senegal, we needed a system for motivation. We need really to respect the community dynamics and find local solutions, health systems that are supported by the community.
We had some really key points on ensuring that the community has confidence in the approach in order to get acceptance, to be really clear about those objectives, and especially if they're policy oriented, to ensure that the government is taking a leading role. And then finally, from Dr. Aliou in the Senegal country example, to ensure that there are local solutions to some of these, to some of the issues and challenges that you face when implementing. So a really, really big thank you to those three country examples and to our colleagues who presented them. Very, very informative. I'm going to hand over now to Pilar, who will be closing the session today. Over to you, Pilar.
Merci beaucoup, Sophie.
Thank you very much, Sophie, for allowing me to close this session. Very, very interesting. So quickly, I would like to thank the three panelists. Very important and interesting examples that they shared with us. I will like to share the notes that I took. The first conclusion for me is to indicate that the community health workers for treating malnutrition, we know that this is a reality, and not only because of the results that James shared with us, but also because of the implications and engagement with the health minister. We can see the first thing, and Dr. Mathieu presented this information. She participated in this session with us. And we also need to look at the case of Kenya, and James stated the importance of the engagement of the Ministry of Health of Kenya. If we have the persons responsible to develop this approach, we already are getting there because we will get there. second point is to state that this approach, it can be useful also in different contexts. We had the presentation of Senegal and Kenya, and we can see that we have this context of development. And with this presentation was very important, interesting, that of Sudan and Somalia, with in terms of humanitarian context, and this approach already started. So it's necessary to continue seeing the good results, seeing that the approach is useful and it works at a development and humanitarian level. The last point is also the purpose of this session. We had the presentation of a lot of tools for registration, recording, and indicators, also to understand the handling at the community level. I would like to state that if we really want to institutionalize and have an operational approach, we will really need to follow the Ministry of Health or integrate the information at the level of the Ministry of Health. We should be able to integrate the work of the community health workers with the system of monitoring and evaluation of each country where we need to implement this approach. Thank you very much, Sophie. The floor is yours.
Great, thank you, Pilar, and back to Andrew for the closing of the session.
Well, first of all, I'd just like to thank everyone for attending today. Thank you to all of the amazing panelists and presentations and all of the hard work that went into the information that was so clearly presented from everyone. So thank you very much to everyone for their hard work and the great questions that were put forward by the participants today, and to UNICEF as well for organising today's, well, the whole week of workshops. So I hope everyone's found it useful, and I look forward to engaging with everyone tomorrow on our next session. Have a great Wednesday. Thanks, everyone.
Thank you.